Hi everybody, and welcome back to Unit 2 and our discussion of Chapter 6, the cardiovascular system and its control. So when we're talking about the cardiovascular system, it has several different functions. The ones you're probably the most familiar with are the fact that our cardiovascular system delivers oxygen and nutrients to our tissues and then therefore removes carbon dioxide and other wastes. Our cardiovascular system can also transport hormones and other molecules and proteins dissolved in the blood. It also helps support temperature balance and controls our fluid regulation. It also will be very important for maintaining acid-base regulation and regulating our immune function. So, what actually makes up the cardiovascular system? So, the cardiovascular system has three main elements: the pump, which is the heart, our channels and tubes, which are our blood vessels, and these will be important to carry our fluid medium or our blood. For all of this together, our heart will then generate pressure to drive the blood through the vessels, and then the blood flow has to meet any metabolic demands. This means how fast this fluid travels through our blood vessels is going to determine how our metabolic needs are met. So, looking a little bit more closely at the heart, our heart is made up of four chambers. There are the right and the left atria. These are the top receiving chambers of the heart, and the right and left ventricles. These will be the bottom pumping chambers of the heart. Our heart is also surrounded by a pericardium. This is a tissue that surrounds the heart, so it can sit in the pericardial cavity. And then the pericardium is going to be actually filled with pericardial fluid. This is going to allow the heart to beat fluidly and smoothly within this cavity without any friction or rough spots. So, how is blood going to actually travel through the heart? So the right side of our heart we refer to as our pulmonary circulation part of the heart, or the pulmonary circuit. Its main job is to pump deoxygenated blood from the body to the lungs. This pathway goes from the superior and inferior vena cava or vena cava to the right atrium, through the tricuspid valve to the right ventricle, through the pulmonary valves to the pulmonary arteries, and then to the lungs. The left side of our heart is our systemic circulation, and this gets blood to the rest of the body. Its job is to pump oxygenated blood from the lungs to the body. This will go from the lungs to the pulmonary veins, to the left atria, through the mitral valve to the left ventricle, and then through the aortic valve to the aorta. Now let's look a little bit closer at our actual contractile tissue within the heart. This is referred to as myocardium. This is our cardiac muscle. Our left ventricle has the most myocardium. Why would that be? So that is mostly because the left ventricle's job is to pump blood to the rest of the entire body. This means that it needs to have the thickest walls with the most hypertrophy, and then we know our left ventricle will hypertrophy with both exercise and disease. Left ventricular hypertrophy due to exercise is very beneficial. It means that it is stronger and can pump blood more efficiently. However, if we're having hypertrophy due to disease, this is not a functional type of hypertrophy and tends to cause dysfunction within the heart tissue. But as I said, exercise adaptations and disease adaptations differ greatly. Exercise-induced left ventricular hypertrophy, great thing. Disease-induced left ventricular hypertrophy, not a good thing. So, looking at the myocardium, it's only going to consist of one fiber type, and this fiber type is very similar to the type 1 muscle fiber types that we see in skeletal tissue. It will have a very high capillary density and a high number of mitochondria, as well as striations to allow smooth fluid and strong contraction. This makes sense because we don't want the muscle tissue of the heart to ever tire out, and we want it to be properly fueled. Our cardiac muscle fibers are also going to be connected by something called an intercalculated disc. These are going to be desmosomes that help hold the cell together. This is a very strong connection and very difficult to break. If you think about what the heart needs to do, it needs to contract over and over and over again, and we don't want to cause any tearing or damage to that muscle tissue. So, additionally, cardiac cells have gap junctions, and this is going to allow action potentials to communicate between cells very quickly. Gap junctions are what they sound like. They are actual gaps in the joining together of the cells. So my action potential signal can go from one cell to the other very quickly. So this combination of a desmosome, which is going to give great strength to that connection, but also the gap junctions for clear communication, means that our cardiac cells not only have strong interconnectivity, but also can communicate with each other very efficiently. So, main differences between myocardium and skeletal muscle. Our skeletal muscles, as we've already talked about, are large, long, and unbranched with multiple nuclei. They're also going to be intermittent in their contractions as well as voluntary. They are going to contract from calcium release from the sarcoplasmic reticulum. Myocardial cells, on the other hand, are going to be small, short, branched with one nucleus. Their job is to have a continuous involuntary rhythmic contraction. They will also have calcium-induced calcium release. So a little bit of a different activation mechanism as opposed to skeletal muscle. So this is a really nice summary slide of the differences between skeletal muscle and myocardium or cardiac muscle. I would take a moment to pause the video here and kind of review this for your notes. So how does the myocardium actually get blood supply? So this is going to be through our coronary arteries. So the right side of the heart will be supplied by the right coronary artery. And this right coronary artery will further subdivide into the marginal and the posterior interventricular arteries. The left side of the heart will be supplied by the left or the main coronary artery, which will then divide into the circumflex and the anterior descending artery. These are going to be very important, that even though the heart is bathed in blood, it needs its own blood supply to get to the particular tissues. When you lose blood supply to the heart, this is how we get things that are called myocardial infarctions or heart attacks. We can also have issues with heart blood supply through atherosclerosis, which is a hardening and thickening of the arteries, which is going to lead to coronary artery disease, which can also lead to myocardial infarction or heart attacks. So this is a visual representation of what we just discussed. This would be another great time to pause your video and review for your notes. All right, so how do we actually control our heartbeat? This is going to be through our cardiac conduction system. Our heart has something unique about it called spontaneous rhythmicity. That is because there are specialized heart cells that can actually generate and spread electrical signals and electrical currents. These are going to be in 4 particular areas. The first is your sinoatrial node or your SA node. The next will be your intraventricular node or AV node. Next will be your AV bundle, also known as the bundle of His, and your Purkinje fibers. I'll talk about these a little bit more here in a second. But basically what's going to happen is these cells that have spontaneous rhythmicity are going to send a signal out through the heart. And that electrical signal is going to spread rapidly through the gap junctions. Our intrinsic heart rate is somewhere around 100 beats per minute. And we know this because we observe this in our heart transplant patients. This is because there's no actual neural innervation from the vagus nerve to that heart because it had to be cut during the transplant. So we know this spontaneous rhythmicity hangs out at about 100 beats per minute. And then we can kind of adjust up and down through hormones, nerves, and other functions. So with this cardiac conduction system, our signal is going to initiate at the SA node. This will be made of pacemaker cells, and it is going to hang out in the upper posterior right atrial wall. The signal will spread from the SA node via the right atrium and left atrium down to the AV node, and this is going to stimulate right atrium and left atrium contraction. There will then be a delay at the AV node, and then the signal will relay down to the ventricles. The AV node is going to be located on the right atrium wall near the center of the heart. This delay is going to allow the right atrium and the left atrium to contract before the right ventricle and the left ventricle. And then from the AV node, the signal will go down through the AV bundle. So when the heart contracts, you're going to have the atrium that contract, a short delay, and then the ventricles. If I'm actually listening to somebody's heartbeat, you can actually hear this occur. You can hear the lub, dub, or the bump, bump in the heart. So that would be atrium, ventricle. You can actually hear this delay occur. So from our AV bundle, the signal will be sent down to the right atrium and the left ventricle, and this is going to travel through the interventricular septum, the space in between the ventricles. This will divide out into the right and the left bundle branches and send the signal towards the apex of the heart. From here, Purkinje fibers will send the signals to the rest of the right ventricle and left ventricle. And these Purkinje fibers are going to form terminal branches. And then from the terminal branches, this will spread through the entire ventricle wall and stimulate full ventricle contraction. So another great picture. So if you are a visual person, this will show you the path of the conduction system through the heart. So now how do I control my pacemakers? So our main control system for the heart is going to be our vagus nerve. This is our 10th cranial nerve. It is the only cranial nerve that really leaves the kind of head and face area, and it's going to travel directly down to the heart. Its main job is to carry impulses to the SA and the AV nodes, and it does this by releasing acetylcholine, and its job is to hyperpolarize cells. Therefore, we can decrease heart rates and the force of contraction. When we want to decrease the heart rate below the intrinsic heart rate, so if you remember, our intrinsic heart rate is around 100 beats per minute, but an individual's normal resting heart rate is somewhere between 60 and 100 beats per minute. And then our highly trained endurance athletes can be somewhere around 35 beats per minute. So this means that my vagus nerve can actually release acetylcholine down, hyperpolarize these cells, and decrease my resting heart rate. So this is an active process to bring your heart rate down below this intrinsic heartbeat. So, as you would expect, the sympathetic nervous system has an opposite effect to the parasympathetic nervous system. Its job is to carry impulses to the SA and the AV nodes through the release of norepinephrine, which is going to facilitate depolarization. This means we can increase our heart rate and the force of contraction of the cardiac muscle. Our endocrine system can also exert a similar effect with epinephrine and norepinephrine. We can also see the increases in heart rate above the intrinsic heart rate level, and this is going to be determined by physical and emotional stress. The heart has a maximum possible heart rate of about 250 beats per minute, but this will decline with age and other disease presence. So this graph kind of shows the interaction between the parasympathetic and sympathetic nervous system. So we know the parasympathetic nervous system via the vagus nerve is going to decrease our heart rate, and then our sympathetic nervous system is going to increase it up until our heart rate max. So how do we actually measure electrical activity in the heart? And we do this through the electrocardiogram known as the ECG or the EKG. So the ECG's job is to record the heart's electrical activity. It uses 10 electrodes, which will come out to 12 individual leads. And this is going to give us kind of a 360 view of the electrical activity in the heart. Typically, we use this as a diagnostic tool for any heart arrhythmias, electrical activity dysfunctions, or coronary artery disease. When you look at an ECG or an EKG, there are three basic waves we pay attention to. The P wave, which is going to represent atrial depolarization, the QRS complex, which is our ventricular depolarization, and then the T wave, which is our ventricular repolarization. So this is what an ECG or an EKG would look like. So if you look, you can see several different P waves here. This is going to be the atrial depolarization. Then you see the big triangle shape, which is the QRS complex, which will be the ventricular depolarization. Then you have the ST segment. This is going to be ventricular repolarization, which goes into the T wave, which is also ventricular repolarization. We also want to pay particular attention to the PR interval. This will give us information about the AV node's delay between the atrium and the ventricle. And then we have the QT interval, which is ventricular depolarization and repolarization. So if you ever decide to work in a clinical setting where you'll be looking at ECGs or EKGs quite regularly, that's kind of what these represent. So using an ECG or an EKG, we can identify a few different cardiac arrhythmias. So the first being bradycardia. This is pathological versus exercise-induced. You can also have exercise-induced bradycardia. Bradycardia just means a slow heart rate. So the more fit you become, the slower your resting heart rate will be. If you have bradycardia due to that, that's not necessarily a bad thing. However, if you have a disease or disorder that causes bradycardia, this could be a problem. Typically, we give you medication for that. Tachycardia is the exact opposite of bradycardia. Tachycardia is when you have an accelerated resting heart rate. We know that heart rate is going to increase during exercise, so that's an exercise-induced tachycardia. Not inherently a bad thing. However, if you have pathological or disease issues going on that are causing an increase in resting heart rate, we need to know about that. There is also premature ventricular contraction. This means that the ventricles of the heart are not fully full, before they contract, so we're not getting efficient circulation of blood through the systemic system. Atrial flutter or atrial fibrillation is when the atrium don't fully contract, they just kind of twitch. This is very common in older individuals, which means we're not getting blood efficiently into the ventricles. And then you can also have ventricular tachycardia, so a fast ventricular heartbeat, which means that your heart kind of skips a beat. You may have felt this before. And then ventricular fibrillation is deadly. It means the ventricles aren't actually pumping, they're just twitching, and this can kill you. So we don't like that one. So now that we've kind of talked about the heart's basic structure, function, and electrical activity, let's talk about the actual functional jobs the heart has. So there's a few different terms that I need you to be aware of. The first being cardiac cycle, the second being stroke volume, third being ejection fraction, and fourth being cardiac output. And we're going to dive into these a little bit deeper. So looking at your cardiac cycle, this is basically all of the mechanical and electrical events that are going to occur during one heartbeat. We break down the cardiac cycle into two phases, diastole or distole, which is the relaxation phase. This is when the chambers are filling. It's going to be twice as long as systole, and then systole, which is the active contraction phase. So when we're going through the cardiac cycle, the heart is either filling or pumping. So diving into this a little bit deeper, we have ventricular systole. This is going to be the QRS complex and to the T wave. This is going to account for about a third of the cardiac cycle. How this is actually going to work is your ventricular pressure is going to increase, the AV valves will close, that's your first heart sound, the lub, then the semilunar valves will open, blood will be ejected, and then at the end, the blood in the ventricle will create something called our end systolic volume. So every time the heart beats, even if it has a very strong contraction, it's not necessarily going to fully empty. There's going to be a little bit of blood left over. And this is basically the start to the end of ventricular systole. Ventricular diastole or distole is going to be from the T wave to the next QRS complex, which will make up about 2/3 of the cardiac cycle. This is when the heart is going through relaxation and is actively filling. To get this to happen, ventricular pressure will drop, and then the semilunar valves will close. This is your dub sound. When you're listening to heart rate, your AV valves will then open, and there will be about a 70% passive filling of the ventricle, and then the last 30% by active atrial contraction. This means at the end of this, we will have blood in the ventricle that equals the end diastolic volume. So all of these interactions between the electrics of the heart and then the volume changes is represented here in this slide. I do recommend that you pause the video here and spend a little time digging through this. Our next concept we need to be aware of is stroke volume and ejection fraction. So our stroke volume is the volume of blood that is going to be pumped in one particular heartbeat. So, as I've mentioned already, during systole, most, but not all of the blood will be injected. This is going to be the difference between the end diastolic volume and the end systolic volume, which gives us our stroke volume. So for example, if we have 100 milliliters for our end diastolic volume and 40 milliliters for our end systolic volume, this means our stroke volume would be 60 milliliters. From there, we can calculate your ejection fraction, which will be the percent of the end diastolic volume that is actually pumped out. So you can think of this as systolic volume divided by end diastolic volume. So 60 milliliters divided by 100 milliliters gives us a 60% ejection fraction. This is kind of a clinical index for heart contractile function. When we start dropping below 60% contractile functioning, we start to say that somebody has heart disease. So our last essential kind of vocabulary term to discuss is cardiac output. This is going to be the total volume of blood pumped per minute. We calculate this by taking your heart rate times your stroke volume. So in our example here, we'll take a resting heart rate of around 70 beats per minute and a standing stroke volume of around 70 milliliters per beat. This means that we multiply these two together, so 70 times 70 will give us 4,900 mLs per minute, or about 4.9 liters per minute of blood circulation. So our resting cardiac output is going to be somewhere between 4.2 to 5.6 liters per minute. So that means on average, we move a total volume of blood of about 5 liters around the body every minute. This total blood volume will circulate once every minute. So let's talk about exercise. When we are exercising, there are two kind of essential things that the heart does to help us get more blood circulating when we're moving. The first is functional synctitum. This is the pumping of the heart as one unit. So we know that there's going to be coordination going on within the heart. And the second part is torsional contraction. This is when we have an increased contractility during intense activity that's going to enhance the left ventricle filling. So there's going to actually be some twisting of the heart within the pericardium when we go through heavy bouts of activity. So during systole, the heart will twist gradually, storing energy like a spring, and during diastole, it will abruptly untwist to allow atrial filling. This is called dynamic relation. So if you've ever done very high intensity bouts of activity, you may actually start feeling your heart beat very strongly in your chest. You may actually also feel kind of that twisting motion, and that is going to be the torsional contraction. Looking a little bit deeper into our blood vessels, we have our vascular system. There are 5 distinct types of blood vessels that we interact with. The first being arteries, whose main job is to carry blood away from the heart. Then your arterioles, they are kind of a transition between an artery and a capillary, and their job is to control blood flow and feed the capillaries. Our capillaries are then our site for nutrient and waste exchange, which will then travel to the venules, which are a transition between the capillaries and veins. Their job is to collect blood from those capillaries, and then our veins, which carry blood back from the venules back to the heart. So within these particular vascular structures, we want to pay attention to blood pressure. So blood pressure is going to be the pressure of the blood in these particular vascular systems. We pay attention to 2 distinct blood pressure measurements, the first being systolic blood pressure. This is the highest pressure in the artery during systole. In a healthy individual, we expect this top number to be somewhere between 110 to 120. And then our diastolic pressure is going to be the lowest pressure in the artery during diastole. We expect this bottom number to be somewhere between 70 and 80. So the next important concept to discuss with blood pressure is the general hemodynamics, or the general dynamics of the blood. So blood flow is going to be required by all tissues. This is because blood helps disseminate oxygen, carbon dioxide, and other nutrients to the essential tissues. The way we can regulate hemodynamics is through pressure and resistance. So pressure is going to be the force that drives the flow. This is provided by the heart contraction, and our blood is always going to flow from a region of high pressure, so the left ventricle and the arteries, to the regions of low pressure, so the veins and the right atrium. This is going to continue to drive flow through the pressure gradient. So we have 100 millimeters of mercury to 0 millimeters of mercury, which will give us a pressure gradient of about 100. The other important concept is resistance. So this is going to be any force that opposes flow. This will be provided by the physical properties of the vessels, mostly with the radius of that particular vessel. So the easiest way to change flow, speed up flow or slow down flow, is to change the resistance. We can do this through vasoconstriction, so constricting the arteries and other vessels, or vasodilation, so widening the arteries or vessels. By this interaction of constriction and dilation, we can divert blood to regions where it is most needed, which means I can send nutrients and oxygen and get rid of CO2 through a diverse array by changing resistance. Our arterioles are where we're going to see the most resistance change. These are considered our resistance vessels, and it is their job to control the systemic resistance. This is where we're going to see the most potent vasoconstriction and vasodilation. This means that our arterioles specifically are responsible for somewhere between 70 and 80% of any pressure drops that occur from the left ventricle to the right atrium. So as we can see here, this is a graph that demonstrates our pressure differences. So as we go from the left ventricle all the way across to our large veins, you can see the pressure differences as we go. So our blood flow is also going to impact our cardiac output. That is because when we have a change in pressure, and we know our pressure gradient is what drives our flow. This means we're going to have pressure change differences between our left ventricle and our aorta and our vena cava and our right atrium. And again, we talked about resistance is going to be what changes this, and this is going to be via vasoconstriction and vasodilation. So where is blood distributed in the body? Our blood flow will go to sites where it is needed the most. So most often where we have regions of increased metabolism, we will also have increases in blood flow. So for example, after eating, where would it make sense for all the blood to go? Typically to the GI tract, because this is where we're having the most activity. However, if it is hot outside, it makes more sense to send a lot of the blood flow to the skin so we can let off heat. So at rest, our cardiac output is somewhere around 5 liters per minute, as we've previously discussed. And during rest, our liver and our kidneys are receiving about 50% of our cardiac output, and our skeletal muscle is receiving somewhere around 20% of our cardiac output. However, once I start participating in heavy physical activity and exercise, my cardiac output is going to drastically increase to around 25 liters per minute. And above that, our exercising muscles are going to receive somewhere around 80% of our cardiac output because of regionalized vasodilation. Our blood flow to the liver and kidneys is going to be decreased through vasoconstriction. So because I've had vasodilation and vasoconstriction, even though I've increased my cardiac output, I can send blood to different regions of the body. So this would be another good time to pause your video and take a moment to kind of analyze this chart. This is showing the main differences between rest and heavy activity and the percentage of blood flow that is going to each of these particular regions. All right, so we also need to talk about some other controls of blood flow. Intrinsically, local tissues are going to have the ability to constrict or dilate arterioles that serve them. This is going to alter regional blood flow based on need. So it's not just a systemic change, we can also have regional localized changes. Our 3 types of intrinsic control that allow us to do this are metabolic, endothelial, and myogenic. So our metabolic mechanisms is going to be the buildup of local metabolic products, as well as the decrease in oxygen concentration and an increase in carbon dioxide, potassium ions, hydrogen ions, and lactic acid. So this means when we have a buildup of metabolic wastes, I need to create vasodilation to clear those out more efficiently. Our next one is going to be endothelial. This also mostly reacts as a vasodilation. And this is when we have substances secreted by our vascular endothelium, so the endothelium, that inner lining of our actual blood vessels. Typically, what is going to do this is the presence of nitric oxide, prostaglandins, and EDHF. And then our final intrinsic control will be myogenic mechanisms. These can create either vasoconstriction or vasodilation. So when we have local pressure changes, as I said, we can have vasoconstriction or vasodilation. So whenever we see an increase in pressure, we can see an increase in vasoconstriction, whereas when we see a drop in pressure, we see an increase in vasodilation. And extrinsic controls of blood flow, we can also have neural controls here. These will be upstream local intrinsic controls, and this will allow us to redistribute organ and system level blood flow. So our sympathetic nervous system, which will innervate smooth muscle in our arteries and arterioles, is going to be what takes over here. We have a baseline level of sympathetic activity, which creates our vasomotor tone. So when we increase the sympathetic activity, we get vasoconstriction. When we decrease sympathetic activity, we actually just get a decrease in vasoconstriction, which is a passive form of vasodilation. So this is your first real exemption of the rule that sympathetic nervous system always cranks things up and parasympathetic always calms things down. In this particular instance, our blood vessels are not controlled by our parasympathetic nervous system. It is only by the sympathetic nervous system, which can either cause more activation, which will be a vasoconstriction, or less activation, which would be a passive vasodilation. So let's zone in on the muscles next. So if we want to increase the blood flow to an exercising muscle, we need it to match its metabolic demand. That means locally I can alter blood flow and improve the extraction at the tissue level. And this extraction can be oxygen or metabolic needs. This is functional sympatholysis. Sorry, I can't say that word. This is when we inhibit the sympathetic vasoconstriction by reducing vascular responsiveness to our androtic receptor activation. That means that I'm kind of ignoring that vasoconstriction signal and remaining open so I can keep blood flow there. So the next thing to consider is we have talked about getting all this blood to the muscles. Now, how do I get it back to the heart? And we know we do this via the veins. So at rest, our veins contain about 2/3 of our blood volume, and our veins are highly elastic and balloon-like, so they have a high capacity to hold our blood volume. You can also think of your veins as a blood reservoir. So because our veins are creating a blood reservoir, we can also liberate this and send it back to the heart and to the arteries. We do this through sympathetic stimulation and venoconstriction, or constriction of the veins. So why does this all matter? There is an integrative control of our blood pressure. So we have autonomic reflexes in addition to other hormonal aspects that maintain our blood pressure. The first thing to be aware of are our baroreceptors. These are going to be receptors that are sensitive to change in arterial pressure. And then they will send afferent signals from the baroreceptors up to the brain. And then efferent signals will be sent back from the brain to the heart and the vessels. And they will adjust arterial pressure back to normal. We also have our chemoreceptors and mechanoreceptors in the muscle that are going to give us information as well. So getting this blood back to the heart, we have an upright posture, which means blood tends to just hang out and pool in the veins. So it's more difficult to get blood back to the heart when we are standing. So we have 3 different mechanisms that are going to assist with venous return. The first is one-way valves within the veins. So these valves, once blood flow goes up, it can't back flow into the previous segment. So these valves are very important. The second is your muscle pump. So whenever you have muscular contraction that is near a vein, it kind of milks the blood back up towards the heart. So with every muscular contraction, you're helping return blood to the heart. And then we also have our respiratory pump, which we will talk about in chapter 7. Whenever you breathe, the intra-abdominal pressure that you create is also going to help push blood back up to the heart. All right, our last topic is let's talk about what blood actually is. So blood has 3 major functions: transportation, temperature regulation, and acid and base balance. Typically, blood volume, there are 5 to 6 liters of blood in men and 4 to 5 liters in women. Why is there a difference? Well, typically men have a larger body size than women, and the blood volume compensates. When we talk about blood, we're typically talking about plasma and a combination of different formed elements. So our blood is composed of plasma, which is somewhere between 55 and 60% of the blood volume. Plasma can decrease by up to 10% with dehydration and the heat, and it can also increase by up to 10% with training and heat acclimatization. Plasma is made up of about 90% water, 7% other proteins, and 3% nutrients, ions, and other substances. Then within the blood, there's also formed elements. This makes up between 40 and 45%. This is composed of red blood cells, white blood cells, and platelets. And then the last little bit is your hematocrit. This is the total percentage of the volume of the blood composed of those formed elements. Red blood cells are unique. They have no nucleus, so they cannot reproduce, they cannot repair themselves. So once they are damaged, they need to be destroyed. This also means that your body needs to constantly be making new red blood cells. So red blood cells are replaced regularly via hematopoiesis. They last around 4 months in the body, and then they are destroyed at equal rates of production. Our red blood cells contain a component called hemoglobin. This is our oxygen transporting protein in our red blood cells. So you can fit 4 oxygen molecules per hemoglobin. Heme is the pigment that also holds iron and oxygen. And then globulin, or the globin, is the protein that kind of holds the hemes together. You have 250 million hemoglobin per red blood cell. So then we know each hemoglobin holds 4 oxygen. So your blood has the capacity to hold a lot of oxygen. This means our blood can carry about 20 milliliters of oxygen per 100 milliliters of blood. Our final thing that we need to be aware of blood is the blood viscosity. So our blood's thickness is due to red blood cells. It is twice as viscous as water. And as our viscosity increases, our hematocrit increases as well. We need to have a plasma volume that will increase just as much as our red blood cells increase, because if we have too many red blood cells compared to plasma, that blood gets too viscous, kind of like the consistency of a thick maple syrup or a molasses, and it gets stuck in places it shouldn't, and it can cause cardiac arrest. So this increase of plasma volume as well as red blood cells can occur in athletes that have trained to have high levels of endurance, or they can acclimate to heat or altitude. But our hematocrit to viscosity ratio needs to stay stable. Otherwise, blood flow and oxygen transport is going to suffer. So that is the last of our discussion of Chapter 6. I look forward to hearing back from you guys for Chapter 7.